Now go on to our next speaker, Dr. TAMILARASI, who's a senior consultant, cataract and intraocular lens services from the Eye Foundation group of hospital, and she's a surgical trainer and has a phenomenal surgical understanding of the whole process of cataract surgery. And she is going to be showing us a lot of pearls in her presentation. On to you, Tamil.
Thank you, ma'am. Good afternoon all. Mr. Sharik, can you play the video from your side?
Good afternoon all. Today I am going to share a surgical video audit of posterior capsular fracture managed by a junior surgeon and analyze the decision-making process which could be of benefit for others when faced with similar situation and hence improve their surgical performance. This is a nuclear sclerosis grade 2 cataract, well-dilated pupil, adequately sized rhexis is done, a cortical cleaving hydrodissection and the nucleotomy technique of stop and shock is performed. During quadrant emulsification, at the last quadrant, surge at the phaco tip snagged the posterior capsule, leading to a small punched out posterior capsular rupture. At this stage, my aim would be to stabilize the anterior chamber. So hence go to foot pedal position 1, exchange the second instrument with the dispersive OVD and inject, form the anterior chamber, plug the posterior capsular end and then withdraw the phaco probe. The prolapse and the loss of vitreous does not always have to happen. We can check for it by using tricot. Since the nuclear fragments are small, it could be expressed using a sandwich technique, do a complete cortex removal and plan for the in the back single piece IOL placement. But what happened was, phaco was continued, AC destabilized, vitreous prolapsed and PCR enlarged. Withdrawing the hand immediately also invited more vitreous to come forward. Poor visual results did not occur from losing vitreous but from complications related to intra-op and post-op vitreous traction. Primarily, we want to prevent vitreous traction intraoperatively and avoid it post-operatively. The question is whether or not the lens material is mixed with vitreous. So identifying this and doing adequate vitrectomy would have prevented the intra-op vitreous traction. Though IOL scaffold helps to compartmentalize the posterior segment from the anterior chamber, this technique could be problematic if the nucleus is entangled in vitreous or if there is an uncontrolled large posterior capsule rupture. Here, while trying to implant this single piece IOL in sulcus, the nuclear piece which was entangled in vitreous flipped and dropped into the vitreous. Avoid vitrectomy through the main clear corneal incision because the AC is going to collapse and the vitreous is going to flow out more, though here the IOL is tamponading the area of PCR. And use the irrigation cut aspiration for anterior vitrectomy and IA cut for epinucleus and the cortex removal. When I was called for help, all I could see is the presence of cortex 360 degree. I could see the rhexis margin well and a small nuclear fragment in the anterior vitreous face and a single piece IOL in the sulcus. So my plan was to do complete cortex removal, assess the extent of PCR and then decide on choice and the placement of the IOL. I used the bimanual irrigation aspiration for cortex removal. Since the IOL optic was tamponading the area of PCR, there was not much of prolapse of vitreous thereafter. I could easily remove the cortex at all areas except at the placement of the haptics where it was trapping the cortex. So I have to stop in between, inject viscoelastic, dial the lens so that I could easily aspirate the cortex at the area of the haptics. So once after dialing in, I could easily aspirate the cortex at that area. Once complete cortex removal is done, all I could see is an PCR with irregular margins which was large. So to start with it was small and now it is large. So the options left were to convert the PCR to PCC and then place a single piece IOL in the bag, which I was not comfortable doing, or to explant the lens and place a 3-piece IOL in sulcus with optic capture. Since the patient was a low paying patient, I had to place a rigid 6 mm optic IOL. I was not comfortable in extending the clear corneal incision because it's avascular and it will take longer time to heal and it's going to induce a large amount of astigmatism. So I fashioned a superior sclerocorneal tunnel and implanted a 3-piece IOL in sulcus with optic capture. I sutured the wound, did a thorough viscoelastic wash to prevent post-op IOP spike. There the patient did well after PPV and the epinuclear removal. He had a BCVA of 6.6 and these are the post-op pictures. Thank you for the patient listening.
Thanks a lot, Tamil. That was a wonderful teaching video for all of us. So there are, the first question I would ask is, what would you have to say about the basic principles of vitrectomy, which you would need to use in this particular case?
Yes, ma'am. For a beginner surgeon, it was discussed, it is always better to use a diluted tricot to see the vitreous and use the vitrectomy in the mode of irrigation cut and aspiration. Each machine has a maximum cut rate. In a Signature Pro, we have 2500 and Centurion 4000. So use the maximum cut rate, vacuum of around 250, and aspiration flow rate of 20 to 25. And always do vitrectomy first in the anterior chamber at the section and then move to the site of PCR with a probe facing up or sideways. And if there is presence of any epinucleus or cortex, then we can shift to the irrigation aspiration cut mode and do the epinuclear and cortex removal.
As far as the probability of a surge, which could have triggered that PCR at that point of time, what are besides all the machine inbuilt facilities to prevent surge, what else could be done to avoid surge in these particular cases?
Apart from the machine factors, ma'am, as a surgeon, we have to concentrate on a perfectly sized tunnel which does not leak, and use an optimal aspiration flow rate and vacuum which the surgeon is comfortable with. And during the last piece, it's better to come to an epinucleus mode as a beginner surgeon, and always aim for a partial occlusion phaco where you don't go for a full occlusion so that we expect surge. So
Yes.
these are the factors as a surgeon we can see.
Dr. Gaurav or Dr. Ramurthy, I just wanted to ask you, does it make sense to have placed a single piece IOL as a scaffold at all? If you have decided on a scaffold, probably it should only be a 3-piece IOL.
No, I think scaffold should not have been done at all. I mean, the scaffold is okay when there's just a PC rent and anterior hyaloid face is still intact. And then you have a mechanism to separate it out and bring the nucleus in front of the lens. But as Tamil rightly mentioned, once there is a vitreous disturbance, vitreous in the AC, and it's all a mess with the vitreous mixed with the nucleus, any type of lens should not be placed. I mean, the more important thing is to clean up the vitreous, because once you place the lens with the vitreous in the AC, there's going to be a lot of traction that it's going to create. And if at all, even if you have a reasonably size rent, and as she was mentioning, it's a dining surgeon, it might be a good idea to place a 3-piece lens in the sulcus if the vitreous phase was not disturbed, because that's more versatile. You can finally dilate it into the bag or leave it in the sulcus, or if it has to be even converted into a scale fixation lens, that's amenable to that.
I agree. Dr. Arun and Dr. Gaurav, anything to add before we go on to our next video?
I just want to ask one question to Tamil.
Yes.
When you went in Tamilarashi,
Yes, sir.
when you went in with the biomanual, why you didn't check with the tricot whether the vitreous was there or not?
So actually, the first surgeon who has done, he has done a thorough anterior vitrectomy. He has stained it and done, sir. So I felt that the need was not there. He has done, sir, actually. That part was edited.
Yeah. Ideally, you should have just put tricot there, made sure, and then done the biomanual. But obviously, the vitreous was not there, but you know about it. But that's the ideal way to go. And what about the nucleus which is there in the vitreous cavity?
She
Yes,
said
sir.
he was done.
Patient underwent secondary surgery after a week for epinucleus removals.
Okay.
Yeah. That was a wonderful teaching video.
Ma'am, just one thing.
Yes, Anaga.
If there was a retina surgeon available, then could a pars plana vitrectomy and removal of that fragment could have been done at the same sitting?
Sitting. Yes, 100%.
Yeah.
That's how it's
That
always
is
done.
probably most ideal, but may not be always possible.
I was planning to ask her separately, Anaga. Why did you do it as a two-stage surgery?
No, I think
There's always somebody
Yeah.
else.
what has to be appreciated was that I was really impressed when I saw her video, the way step by step she brought out all the challenges which were there when she took on that particular case. Wouldn't have been enjoyable doing that case at all. Thank you.